you all for the IPNA Endorsed Webmaster Series 2025. And this series is exclusively on pediatric nephrology on chronic kidney disease. And we had been doing the webinar series for the last 5 years annually. And this is our fifth webinar series. And this year, we are in the last webinar for the year, webinar 8. And the highlights of this webinar series is all practical aspects of pediatric CKD was delivered by most of the experts in the field. And the polling session for the trainees we had been conducting for the last 6 webinars. And today will be the announcement of the polling sessions. Can we move on to the next slide? So I request Dr. Amrish to introduce the moderator of the day, Dr. Mansi Garg. And Amrish, you're there?
Thank you so much, Dr. Kalaivani. As you said, this has been an exciting year. This was fifth consecutive year that IPNA has supported us for the webinars. And this is the final session today, and we are excited about it. We have as our moderator, Dr. Mansi Garg, and we have two excellent speakers today. Dr. Mansi Garg is a professor at Mahatma Gandhi Medical College and Research Institute in Puducherry. Her areas of interest are nephrotic syndrome and acute kidney injury, and she has publications in national and international journals. Thank you, Dr. Mansi, for joining us today. I would hand over to you to run the session.
Thank you, sir, and thank you, ma'am. At the outset, I would first like to congratulate you for the 5th year of completing this IPNA web series. It's an honor to be here to introduce two of the excellent speakers, Dr. Sudarsan and Dr. Neha. Dr. Sudarsan, he has done his DM Pediatric Nephrology from AIMS, and he is currently working as an assistant professor in the Department of Pediatrics, JIPMER, Pondicherry. His areas of interest are acute kidney injury, dialysis, hypertension, and chronic kidney disease. And he has multiple publications in PubMed Index Journal. So I will hand over to Sudarshan to start his presentation on novel biomarkers in chronic kidney disease and its clinical implications.
Thank you, Dr. Mansi. And at the outset, I'd like to thank Dr. Kalaivani for giving me this wonderful opportunity. Am I audible and is my slides moving?
No, your slides need to be projected. You can start sharing.
Okay, I'm in full screen. Are the slides seen now?
No.
Okay.
I guess it is visible.
Yes, I'm also able to see.
You're able to see?
Yes, I was able to see.
Okay, now I can see them.
All right. So over the next 30 minutes, we will try and see some novel biomarkers in pediatric CKD and their implications. I'll try to take over through common scenarios which we see in routine pediatric care and try and see how biomarkers have helped us evolve in these situations. Okay, so let's start with a very simple and commonly used one, the glomerular filtration rate. To begin with, let's do this. A 6-year-old girl comes to us for an abdomen pain, undergoes a creatinine as part of routine testing, and then found to have a creatinine of 0.8. So now the question to us is, are the kidneys functioning well, or does she have CKD? So how do we do that? Routinely, what we have been doing in this scenario is to get a glomerular filtration rate estimated, right? So the most commonly used formula is the bedside Schwartz, which we all know is 0.413 into height by serum creatinine, right? The simple bedside formula, roughly speaking, is about half the height divided by creatinine. So when we do that, we try and achieve at a value that is going to be the eGFR for that particular patient. So 0.8 may seem normal to many people, but when you do this modified Schwartz, we are realizing that the patient's GFR is only 56. Okay, so this is not okay. This is stage 3A CKD already. So then a battery of tests are going to follow. You try and understand why the kidney functions are low and so on. Okay, so the point here I'm trying to say is we are trying to understand the kidney function through a biomarker. So in this case, it has been a simple serum creatinine and apply a formula and try and understand how healthy are your kidneys functioning. Now, one thing we need to understand is how good is this biomarker and how close it is to the truth. Okay, so that is one thing which we need to understand. So is this 56 really 56 or is it something else? So for that, we need to understand the bedside Schwartz, as has been proposed in the 2009 paper. We have to understand these important limitations of this Schwartz equation. So the age group where this is valid is between 2 to 16 years. So it's probably not a good biomarker on either ends of the pediatric spectrum. So we're seeing in adolescents and somebody around 17, 18 years, probably this is not a good formula. The same holds true for in neonates and young infants. Okay, so the accuracy of this definitely falls down. So this value which you get may not be really the same. And when they tried and compared this equation, they realized that it works best at this range of GFR. So a GFR between 15 to 75, right? So stage 2 to 4 is where it has been studied and it applies closely to this specific population. So not really great for somebody who's apparently healthy. Like if this child walks into your OPD just because they got a creatinine for a vague abdomen pain and found a value of 0.8. So probably this is not a very robust marker to pick up. So it's not validated in apparently healthy children. Okay, so we all need to understand this. So every test will have its own sensitivity, specificity. Okay, so you need to know what is the right context where you need to apply each and every formula. So how are we getting better? So that's when cystatin came up. So cystatin has been in vogue for more than 2 to 3 decades as a biomarker for estimating the glomerular filtration rate. People have come up with numerous formulas. The most widely accepted formula for calculating the glomerular filtration rate based on cystatin is this one. So if you get a cystatin measured and just put that value here, you will get a GFR value for this particular patient. So obviously, we all know the downsides of using creatinine is because it's dependent on their muscle mass, the age, and we all know that more than 50% of the glomerular function has to be affected before creatinine starts to jump, right? So cystatin tries and avoids all this. And rough normal values, just to remember, is a value more than 1 beyond 1 year of life is abnormal, okay? So there have been studies where they have shown that the eGFR calculated by cystatin is better over creatinine in multiple settings, especially in the setting of oncology patients, transplant, muscular dystrophies, and so on. So in these patients, probably if you estimate the GFR using cystatin, it might be better. And then now we have this combined formulas, the CK 2012 formula, where they have used both creatinine as well as cystatin. You also feed in other data like what is the blood urea nitrogen, is the patient a boy or a girl, and then try and calculate the eGFR. Don't worry, this formula may seem very daunting, but these are all online calculators available. You just feed in this value and it'll get you the GFR and you just use that as the GFR. So I think most of this is already known to many of us, right? So what is new in this area? So what is new here is the CK under 25 equation. So in many places, especially in the West, pediatricians have started managing patients up to the age of 25. So many of us may follow up till 14 or 16. Some centers maybe till 18. But in many centers now, that has extended into young adulthood where patients are seen till 25. So once you start seeing patients till 25 years of age, you are posed with new set of problems. So we want to try and use one formula towards the entire age spectrum and apply that to calculate the GFR. We have just seen that beyond 16 years, your Schwartz doesn't hold good. So what is to be used there? So in this population, right? So beyond 17, 18 years, what is the formula? So they have come up with CKID under 25 equation. I will just show you what is the significance of this with a simple example. You will understand better. We all should appreciate the jump in creatinine and the eGFR basically during transition to adulthood, okay? So let's see this example of an 18-year-old male who comes to you with a creatinine of 1.2. We all know in adults 1.2, up to 1.4 is probably okay. I'll just brush it off as normal creatinine, right? But if for this patient, because he's 18 years under your follow-up in the pediatric nephrology clinic, you apply your modified Schwartz and estimate a glomerular filtration rate, the value comes as 51. So 51 really is a red herring for us, right? So we all feel very worried. Why is it 51? So appreciate that it may not be really 51, but it is just the lacunae with this formula. Okay. So what adults commonly use is the CKD EPI. Some use MDRD formula. So because now from 18 years onwards, that is what is recommended. So for this patient, if you use the same CKD EP formula and input the same data, okay, you have not changed any data, you input the same data, then you get a GFR which is really 90. So you appreciate the difference between 51 and 90. So if you use the same bedside Schwartz, let's say when you were 17 years, you identified him as CKD stage 3 based on this. The moment he becomes 18, you use the same, because he's transitioned, let's say, to an adult nephrology services, and they start using CKD epi formula, you see the jump in creatinine and the change in the GFR, right? So this is really huge because patients will all get confused. How are you going to counsel them? Somebody with a GFR of 51, you won't counsel the same way with somebody who is having a GFR of 90, okay? So that's when the CKD under 25 equation plays a role. So the formula is more or less similar to what we use as bets, right? Okay, constant into height by serum creatinine. So it is this constant which is trying to explain the entire spectrum of pediatric population. Okay. Similarly, we also have for cystatin constant into 1 by cystatin. So this constant is what you need to feed for these patients. So this table clearly gives us what is the value for that constant. So this is for the creatinine, this is for cystatin. Just you don't get really bugged about all these numbers. You don't need to really remember them. Calculators again are available online. You just need to feed this value and it is going to tell you the EGFR of that particular patient. So just to say that your K, which was 0.413 routinely, could be something like 0.39 to something like 0.51. So this will cover the entire age spectrum. So somebody till 12 years, till 18 years, and 18 to 25, you will probably use this formula, and it's different for boys and girls. So if you apply this, you will probably get a more accurate GFR estimation, which may be more close to the truth than what we do by using a bedside Schwartz. All right. So similarly, we have this formula for cystatin. And one may want to use both. If you have facility to measure both creatinine as well as cystatin, you can take measure this by both these methods and take an average and try and arrive at a EGFR, which is an average of both the values, formulas. So in this study, so the CKD group have shown how good this works. So the dotted lines are the measured GFR. Measured GFR, matlab you are trying to do iohexol clearance, right? Or a DTPA, whatever. So in this study, they've done an iohexol clearance and you measured the patient's GFR. So the dotted ones are the measured GFR and the black dark lines are what we have estimated from this formula, which we just saw. So you can see that for the entire age spectrum, 2 to 18 and 18 to even till 25, this kind of closely mirrors with what is measured. Okay, so compare this against the different other formulas given in B, C, and D, how they deviate from what is measured, you see. Okay, measured is here, this is here, but whereas here and here, it all varies, and between ages also it varies. So this formula was probably more close to the measured value in such patients. Hence, the CKD group has suggested that probably using an under 25 equation will be very helpful for the entire age spectrum. Okay, so that is what has come up very recently. We need more studies naturally to see if this works well in every other ethnicity also, how well it works in the other groups. Okay, so as of now, we have not really shifted to CKD under 25 formula. We are still stuck with a bedside Schwartz, but this is one place where we can lean towards and see how whether it improves the diagnostic performance. Okay. Just to show you the numerous equations that are available, you can use creatinine, you can use cystatin, and you can use combination. And so many people have proposed so many formulae. The most commonly used is bedside Schwartz using creatinine. Schwartz also has a cystatin formula, and you also have a combined formula which you can use. The good thing is online calculators available. You can just choose what you want to use and feed those values, and then you will try and get the GFR for that particular patient and then stage the CKD accordingly and move on. Okay. So the entire idea here is this is what is measured GFR. Now you want to see how close you are able to estimate this GFR. Okay. You're not going to go and do DTPA or iohexol for all your patients routinely, right? So we want an estimate, a surrogate for that. So that is being done by all these formulas. Remember that each formula will have its own differences. It could be either upward or downward. So you need to realize that we are trying to estimate and try to get closer to the truth or the measured GFR, but do realize that each formula has its own plus and minus. So you may not be able to take it exactly at that face value. The values may slightly deviate. So understand the limitations of using bedside Schwartz, okay, and the various situations like how we discussed. Okay, so let's move on to second scenario, acute kidney injury. Okay, we commonly see AKI in our intensive care settings. So I would want to know which group of patients will require dialysis for this AKI. A lot of patients may have stage 1 AKI. Many of us do not even pick that up routinely. When we look at the charts later, we realize, oh yeah, creatinine has risen by 0.3, so probably it's stage 1, and so on. So, but many times stage 1, we do not even pick up. So all that we are interested here is to see how many of these AKI patients would really require dialysis. Okay. So is there a biomarker which can predict which patients with AKI or a mild AKI will go on to require dialysis? So that is where another biomarker, which is the furosemide stress test, commonly called FST, has shown progress. So the last 10 years, we have seen studies coming up in adults where they have kind of got to a value. You give 1 milligrams per kg of furosemide if patient is naive and 1.5 if it is exposed. And then you look at the urine output in the next 2 hours. Okay. If your value of urine is less than 200 mils at the end of 2 hours, that is 100 ml per hour. So then they are considered FST non-responsive. This is the subgroup of patients who are very likely to go on to develop the need for dialysis. Okay. So if you have a patient with AKI, just give 1 shot of furosemide in a standard format, measure the urine output. If the value is less than 200, then probably you'll take other measures for putting them into dialysis. Not right away, but you know that this is a subgroup which is really at high risk. We'll monitor them closely, and probably these are the ones who will benefit from dialysis. So now what is the value for children? We really know that small children, 200 ml cannot be the cutoff, right? So we need to try and understand what is that value for children. So we did a small prospective study establishing the utility of furosemide stress test in children, and we just published it recently in Pediatric Nephrology. So what we did in this protocol is to give 1 milligram per kg of furosemide and look at the urine output hourly for the next 6 hours. So like the adult one, we hypothesized a value of 2 mils per kg at the end of 2 hours as a cutoff for furosemide responsiveness. So anybody whose urine output is less than 2 ml per kg at the end of 2 hours, okay? So they are considered FST, non-responsive group. So this is the group of patients who are probably at higher need of dialysis. So we tried to show that patients who are non-responsive to FST, about 80% of them went on to require dialysis, compared to only 5% of those who were furosemide responsive. So this is a good deal, right? So 80% you can pick up from those who are non-responsive, and those who are responsive, only about 5% will probably end up having dialysis. And we showed that it is better than traditional biomarkers, NGAL and proenkephalin also. And we were able to show a good AUC for KST of about 0.96. So we concluded that furosemide stress test is a robust biomarker for predicting dialysis need. This was a single center study, so definitely we need to do more studies. There have been some studies in the cardiac surgery setup, but for the entire PICU, like where the ICUs where each one of us work, so we really don't know. We are going to have a mixed bag, right? Patients with AKI due to various reasons. So how good does this test work in this group? We still are not very clear. So this is one study where we have shown that probably it is a robust marker. We definitely need more studies and try and see if this cutoff really holds good, or probably there is a better cutoff for these patients. So here again, we are trying to see how biomarkers have helped us evolve, understand, prognosticate, manage these patients. Okay. So let's move on to another scenario, nephrotic syndrome, which is like the bread and butter of all of us, pediatric nephrologists. We see nephrotic syndrome day in, day out. So the chief query with us here is, when a patient comes to you with nephrotic syndrome, is there any way you can say who is the one who will respond to steroids, who is going to have a SR course, who is likely to respond very well to MMF when compared to cyclophosphamide or probably rituximab, who really needs a CNI? Is this patient going to be having MCD or FSGS on histology? So many such questions go on in our mind, right? So we really need to take help of biomarkers to see how patients evolve and characterize them. So in this context, we have this anti-nephrin antibodies, which has just come up. Pioneering paper came in 2022 in JSON. And then on over the last 2 years, we have had some understanding of these anti-nephrin antibodies. To put these things into perspective, so this is the kidney, glomerulus, we all know that. So this is the triple layer, okay, the glomerular filtration barrier. The red one is the capillary endothelial layer. This is the endothelial cell. The yellow is the glomerular basement membrane, the GBM as we see. This is the one which is affected in Alport syndrome, just for example. And then this is the blue one, is a set of podocytes, okay, with their interdigitating food processes. So this forms the 3-layer framework for the filtration barrier and acts as an effective filtration barrier. So this is the endothelial layer, yellow is the glomerular basement membrane, and this is the podocyte. Okay, this is where nephrin is seen. So putting it in this order, so the capillary endothelial layer, the glomerular basement membrane, and the epithelial layer. So this is one podocyte, this is another podocyte. They're connected together by the slit diaphragm, and nephrin plays a role here. Okay, so if you have anti-nephrin antibodies, so what happens? It goes and binds to this nephrin. So nephrin's integrity is lost now. So then there is a sequence of events, inflammatory reactions, and so on, will lead to food process effacement. And ultimately, the net effect is massive proteinuria and leading to nephrotic syndrome. Okay. So the seminal paper by Watts et al. In JSON came in 2022, where they tried to look at this anti-nephrin antibodies and how good they are. Okay, in understanding the various things that we just discussed, whether they're going to be MCD, FSGS, SS, SR, and response to all these immunosuppressive agents. Is there a way you can predict them by looking at these anti-nephrin antibodies? So they have shown, so this is the initial paper which tried and established a role for these antibodies. So they've done extensive work, lab work. They've looked at the biopsies, they looked at the IgG, they've looked confocal microscopy and shown that all these IgG are in fact anti-nephrin. And from that, then they have shown that about 1/3 in that group, there was the Neptune cohort. So they also had adults as well as children. So about 1/3 in this study group had anti-nephrin antibodies. Over the last 3 years, now we have about 3-4 papers more, which have talked about anti-nephrin antibodies. I'll just summarize in this slide what is currently known about anti-nephrin antibodies. So these antibodies are now identified in about 40 to 50% of children. So about every other child might be anti-nephrin antibody positive. This antibody is more commonly as of now. Okay. So a disclaimer here is this is the data we know as of now. We may evolve in our understanding as we have more studies published, but based on whatever is available current literature, these are the findings. It is more suggestive of a steroid sensitive course. That is, they have identified these antibodies much more in the SSNS group rather than the SRNS group. And they have shown that probably it is seen more often in the MCD group than the FSGS group. This could be underrepresentation, which we have more data, we may know, but definitely even in FSGS patients, in post-transplant recurrence and all so on, they have identified anti-nephrin antibodies there also. Another good thing is, it is the titers really correlate with disease activity. So this is like akin to looking at anti-DNA antibody titers, right, in your lupus patients. So when you're following these patients, you can look at their antibody titers and assess whether they are in activity or not. So similarly, these titers also predict, they correlate with disease activity. And they have so far not shown much of these antibodies in the genetic podocytopathies group. That is the steroid monogenic FSGS patients who have a known genetic mutation. They have not been showing these antibodies in this group. So that group, the pathophysiology is probably because of that genetic monogenic defect, right? So this is the spectrum. We have seen this in as much, okay, up to 60-70%. Also, they've shown in SSNS group, and it just goes down as you go to the SRNS group, and probably virtually not at all in the genetic podocytopathy group. We definitely need more data. We do not have Indian data as yet, so really don't know how these our patients perform, how common is anti-nephrin antibodies in our ethnic group, and so on. So probably this is one space. Over the next few years, we may have more clarity on this. So this will act as a good biomarker, probably telling us by just doing a simple blood test, this biomarker is going to guide us whether this patient is likely to be an SS, SR, and probably with more data, we may be in a position of personalized medicine where we will be able to tell which medication works well. For example, because an antibody, rituximab may be a wonderful agent for this. As of now, we don't have so much data. Probably in times to come, we will know this important information. So a simple biomarker is able to guide you through your treatment strategies. Okay, so the fourth area which I would wanted to explore today is to discuss about cystic kidney diseases. So we see ADPKD, ARPKD, nephronophthisis. Okay, so today we'll discuss about the Mayo imaging classification for ADPKD. Okay, so this classification revolutionized the management of adult ADPKD in a sense that you are able to prognosticate patients. So how do you know which patient with ADPKD is going to rapidly deteriorate, which patient will require more intensive treatment, and so on. So they have looked at criteria like what is the rise in the total kidney volume. Okay, we call it HTTK, height adjusted total kidney volume. So they have been measuring it in MRI. You look at the kidney volume and see what is the growth of the kidneys. If the cysts are growing rapidly, the kidney size is rapidly rising, then probably you know they are poor performers. So you might have to intervene by doing probably some medications, right? And then they also looked at the slope of GFR fall. So what was your GFR last year? What's your GFR this year? And then you see what is your slope, how rapidly you're losing. So if you're losing GFR, let's say 3 to 4 mils every year, then that's probably high risk. And they have categorized them into 1A to E, with E being the high risk, the red group. So C and D are moderate. So basically this criteria came up to help us understand which is the group which will benefit from tolvaptan. Okay. So there is so much data now in adults that high risk, definitely you would start the 1E, 1C and D also after based on informed decision. 1A and B are probably you would not give them tolvaptan. You'll wait and watch and follow them. Okay. So the problem with this classification, so now adult nephrologists have started using this categorization left, right, and center, and people are starting tolvaptan for adults with ADPKD. Now, what do you do for children? So if you see, this only starts from 15 years. So this stratification only starts from 15 years. But by then, we would even transition then to adults. So what do pediatricians do? What do pediatric nephrologists do with these patients? So to that, we have a prognostic marker. The Leuven group came up with a Leuven imaging classification model. So lived at about 75 patients, small number, but remember these are very rare diseases in children. So they've gathered data from these patients. They've looked at the genetic aspects. The best part here is instead of using an MRI, they have used an ultrasound method to follow up. So it's very difficult. Imagine putting a 2-year-old to MRI, you need sedation and all the side effects. Obviously not possible to do a yearly MRI and see, right? Ultrasound, we often do it. So it's very easy. So probably with an ultrasound, is there any way you can predict how these children perform? So will this act as a good biomarker for these patients? So once they did this study, it has just come up recently in CJSN, they have shown that the adult classification doesn't work well in children. Okay, it strongly underestimates the ADPKD severity. I'll just show this here. So these are the Mayo classes A, B, C, D, 1A, B, C, D, which we just saw. We saw that it was only till 15 years. So if you just go back and extrapolate this to the pediatric age group and see what happens, you've seen that most of the patients follow in class A. So we have seen that class A is low risk. So this is quite intriguing, right? You have identified ADPKD in childhood. So you expect naturally that they're going to be poor performers, and why don't you start all of them on therapy and so on? All this go on in our minds. But majority of them have fallen into class A. So there is something seriously wrong with the statistical method used. So what the Leuven group did is they gathered data from their own patients. They did statistical analysis and tried and see if you can match it up to this corresponding classes A to E. And these are the curves which they have drawn and tried to interpost with these adult Mayo classification. Now you see the same between 0 to 15 years age group. This is entirely spread out, right? So you can have some patients who are class A. You can also categorize somebody who is class E. So probably this is a better biomarker as of now. Remember, there's only on very small population, but very well characterized, followed up, genetic data available, ultrasound measured serially, and you have a height adjusted total kidney volume as a marker. So this has just come up. We need to assess this in our setting again and try and see if they're also gathering more data. With more data, we'll probably be able to better identify and stratify this group of patients. So again, another interesting way of looking at how patients will respond. You will be able to prognosticate them better. And we're also interested in starting tolvaptan. As of now, tolvaptan is not FDA approved for children. It is used more than 18 years. We have studies which have shown them to be of use between 5 to 12 years. But yeah, so there's still more data that needs to come up. Probably in the years to come, we will all probably start using tolvaptan also in this high-risk group. But no data as yet, so mind that fact. So over time, we have identified numerous biomarkers looking at the glomerulus, PCT, looking at the DCT markers, looking at tubular interstitium, and so many markers have been identified. The idea here is for us to see which are the patients who will rapidly progress and see if treating this subgroup is beneficial rather than treating the entire lot. Remember, tolvaptan is costly. there is no definite endpoint. You need to keep giving them for a very long time, right? So you choose your patients wisely and apply them carefully. The last scenario which I want to cover today is in the setting of transplant. The only one thing I'll discuss here is the donor-derived cell-free DNA. So we all know DNA lies within the cells, right? So a small sect of this will come out of the cell and is, kind of going in your blood. So this is a cell-free DNA, okay? A part of it definitely goes in our blood. Now we need to know whether this cell-free DNA is from the donor or from the recipient, okay? So that's a huge task. And by this, are we able to identify those who are going to be at risk of rejection? Okay, so you're trying to look at a simple blood test and say the patient is having rejection or no rejection. Okay, so the technology is this. So they've identified single nucleotide polymorphisms. They've identified the donor, the recipient. You amplify them. Thanks to our NGS technology, we are able to do them very well. And you try and arrive at a cutoff. Okay, so there's massive technology behind all this. So we have reformed in our technology over the decades. We still have much more to do, but it has entered clinical arena as yet. That the studies have shown that if the donor-derived cell-free DNA fraction is more than 1%, probably it has about 80-90% sensitivity and 72% specificity to detect acute rejection. So if somebody has a rise in creatinine in the setting of transplant, you want to see what traditionally we would be doing is look at TAC levels and other things and also contemplate a biopsy and see if the patient has rejection, right? And probably if you're suspecting a BMR, then you'll also do a de novo or a DSA and compare it with the de novo values, right? So what happens here is instead of a biopsy, is there a way you can just do a simple blood test and see if the patient is having acute rejection or not? So that's the entire idea. We have not yet moved to that level, but definitely with time, we'll probably get to that stage. So this is the Admiral study, which looked at about 1,000 patients and tried and see if the donor-derived cell-free DNA is able to predict rejection or not. So they have shown that it correlates. It is able to predict those patients who are having rejection. It also correlated with the fall in GFR and also the de novo DSA formation also it was able to predict. So they have suggested a value more than 0.5% is associated with elevated risk of DSA. So the simple way to understand is somebody comes to you in a transplant setting with rise in creatinine. You also do another blood test to look at this donor-derived cell-free DNA. If the fraction is more than, let's say, 0.5 to 1%, there's a high risk of developing rejection. So you will, target that and move in that direction. Okay. So it's too early to say that you will avoid biopsy, but that's the hope. So we are traveling towards that trajectory by a simple blood test if it's able to predict. I'm not sure of the clinical utility as of now. I could just see 1 or 2 studies coming up here and there. Remember, this is from adult literature. We still also need pediatric data on this and much more from the Indian setting. I do not see anybody who has been using this routinely, at least in India. But just to realize that this is another biomarker which is coming up, and probably so in a decade we will have more data, and this is even called the liquid biopsy. So this is currently proposed role of cell-free DNA. So you can use it for graft surveillance. You can identify rejection. You can even correlate this with kidney function and de novo DSA, and also look at antibodies beyond DSA like AT1 receptor antibodies and so on. So from these 5 case scenarios, we have tried and understood how biomarkers have shaped the understanding of pediatric nephrology, how manage patients. And with each of these biomarkers, a simple message. So probably secret under 25 creatinine equation may be preferred in adolescents and young adults. In the setting of AKI, if you want to predict the need for dialysis, the furosemide stress test holds some promise. Antinephrin antibodies have been identified in a subset of patients with nephrotic syndrome, probably more SS than FRSD patients. The Leuven imaging classification improves risk stratification in pediatric ADPKD. And donor-derived cell-free DNA may be a useful adjunct in monitoring transplant patients. Thank you.
Thank you, Dr. Sudarsan, for that extensive simple and lucid presentation. So thank you for that presentation so much. Yeah. So I think we'll be taking the questions after the second presentation is over. So is it, ma'am?
Yeah, towards the end of both the sessions.
Okay, ma'am. So we'll move on to the next timely topic, which is on pediatric CKD, What is the Future by Dr. Neha Bhandari, who has more than 15 years of experience, and she has been a speaker in national and international conferences. She has done her fellowship from Sri Gangaram Hospital and also completed her IPNA fellowship from NUH Singapore. She has more than 20 publications and has participated as faculty in various pieces. She has academic interest in bedwetting and voiding disorders. She has numerous awards to her credit. She has been awarded as Young Researcher Award by Institute of Scholars, Bangalore, Delhi Medical Association for Distinguished Service Award, and she has also been given a Distinguished Daughter Award by IIT in 2022. And she is actively involved in bedwetting clinics since 2016 and a Corona Warrior by Delhi Medical Association. So over to you, ma'am, for the next half an hour for your presentation. Thank you. Will you like to share your slides, ma'am, first, or shall I share?
I'll just try if I can share it again. I think Dr. Mansi, I will request you to share it because
Okay, ma'am, share.
I'll try if I can share.
I'll share.
Yeah. First of all, I would like to say it was a wonderful talk from Dr. Srinivas, so much enlightening for all of us. When we talk about pediatric chronic kidney disease, I was able to follow, and I would like to thank Dr. Kalaivani for giving me this opportunity. Plus, congratulate Dr. Kalaivani and Dr. Amrish for such a successful program that they have done in these 5 years. So I think we have to just make it into a slide format. Uh,
Is it visible now?
yeah, it's visible, but we have to make it into a slide format.
Because I am not able to see that 2 minutes.
Okay. Can you
Just a minute. Is it visible now?
yes, it's visible. Is it visible from my side also?
Is it visible, Amrish, sir?
Yeah, the slides are visible, but doesn't look like in slideshow.
Okay.
If you go on the top orange bar and
Is
then
it
go
visible now?
near animations.
Is it
Yep,
visible now?
Yeah.
Okay. Can I start?
Yes, ma'am.
Okay. Can you move the slides? Yes. So, when we start about pediatric chronic kidney disease, there are a lot of challenges that we have been facing about CKD. So, the most important challenge that Dr. Srinivas has already discussed is measuring kidney function and defining kidney disease in a pediatric population. He has already told us about the biomarkers that we have used, the multiple definitions that I'll be also talking about, which we use, but still some definitions like shorts, we underestimates the GFR, and the CKD EPI is overestimating the GFR. Then we need to know about the genetics in any clinical management and pediatric chronic kidney disease. In a country like India, where it is difficult for us to do genetic test, it is not easily available. That is also one of the limiting factors for us. Then we really need to find out the mechanism of CKD progression in children. So all these things are interrelated. Plus a point about nutrition, which helps in balancing retarding the progression of CKD as well as help in the growth of the children. Then the new therapeutic options for pediatric CKD. My talk will be regarding all these points. So the next slide. So chronic kidney disease, can you, Dr. Mansi, can you change the slide? Yes. So when we talk about chronic kidney disease, the prevalence of chronic kidney disease has never been systematically assessed. Can and consistent information is lacking in the population. The last slide. So you have to just move to the last slide. Yes. So in 2017, the global burden of the chronic kidney disease was around 697.5 million cases were there of chronic kidney disease, and the global prevalence was around 9.1%. So when we define CKD, as per the KDIGO 2012, the CKD is defined based on glomerular filtration rate as well as the extent of albuminuria. But still in children, because in the first year of life, there are a lot of physiological variations as well as there are a lot of issues. So the definition of CKD and defining these children as CKD is challenging as well as underdiagnosis. So once we talk about the advances, next slide. So once we talk about the advances in early diagnosis, like already Dr. Srinivas has discussed about this definition. So when we take Schwartz formula, we consider there is underdiagnosis of GFR. We cannot do a DTPA scan or calculate DTPA GFR for all the children. So in 2021, CKID under 25 came into picture, where they enrolled children up to 25 years of age. In these children, the serum creatinine and cystatin C was taken into account, but the height was not taken into account. So therefore, they avoided the issue of anthropometric data, which was the limiting factor for Schwartz equation. So this was a better way of estimating GFR in these children. This is the basic definition that we are using for children with chronic kidney disease. So in this, if you can actually see from green to red, you can see that these children, once they move from the green part to the red part, their stages is increasing, their proteinuria is increasing. There are multiple factors which are compounding to it, like the children who have low birth weight, who are premature, who have a previous history of AKI, who have taken some nephrotoxic drugs. There is prematurity because of which the nephron mass is low. So all these are contributing factors for increasing the progression of CKD. So how do we assess the kidney function in any newborn? So as he's already told, the serum creatinine is unreliable marker due to multiple reasons that Dr. Srinivas has already discussed. The GFR is low in newborn because of the physiological immaturity. Then once the GFR may vary from 5 to 19 in the first 5 days of life. From after 5 days, there is a biphasic increase in GFR, and by 4 weeks of age, it reaches to around 16 ml. So there are multiple maternal comorbidities also which affect the GFR, like if the mother is having diabetes, hypertension. In cases of preterm infants, there is low birth weight, which again affects the kidney function. So in these cases, as he has already discussed, the cystatin C would be more accurate than serum creatinine for calculating GFR in the first month of life. So this is something that we really want to work upon in future, to use cystatin C more than serum creatinine in assessing the functions. So now talking about early detection and biomarkers. So I will not talk much about it because we have already discussed the whole point of it. So the most important future direction is that we really need to pick these children early. And once we are able to pick them early, we can actually retard the progression of chronic kidney disease. So a lot of biomarkers are still in study, as we are seeing. Plus, there's a lot of research which we have old biomarkers like NGAL, KIM1, cystatin C, which may indicate kidney damage earlier. Then there is development of non-invasive diagnostic tools like urine-based or saliva-based tests, which could further simplify early screening or can detect at-risk patients. So if you talk about blood biomarkers, definitely cystatin C is one thing that we want to work upon. And the next is albuminuria. So proteinuria is one thing which is a very, very important indicator of kidney damage and can be detected as a simple urine albumin creatinine ratio or protein creatinine ratio. Now talking about the urinary biomarkers, urinary exomes is being studied, in which small vesicles released by the cells which hold promises for identifying specific CKD biomarkers. This technique offers non-invasive analysis of urine and could contribute to early detection and better CKD management. Then talking about Raman spectroscopy, this also offers non-invasive analysis of urine and could contribute to early detection of CKD. Now talking about the next part is about the how genetics can help us in uh, retarding the progression of chronic kidney disease. So this I have taken the inner circle. If you can see, it represents primary kidney diseases like podocytopathies, HUS, cystic kidney disease, tubulopathies, Charcot, and this has been, the data has been taken from ESPN, ERA, EDTA registry. So in this, you can see the outer circle is actually representing the proportion of genetic diagnosis according to each group. So this really helps us in knowing, like if you can see, the cystic diseases is almost 56%. You can have the genetic positivity in such cases. So you can actually helps us in picking up diseases by knowing and doing the genetic testing for these patients. So now genetic testing can also identify monogenic causes of chronic kidney disease, like if they can identify mutations in NPH or COL-A4 mutations. Early identification of these mutations allow for targeted interventions, genetic counseling, and even possibility of gene-based therapies. Like sometimes we get children who definitely on clinical scenario looks like RTA to us, but then we cannot point out because the picture is a mixed kind. We can't point out whether it is which type of distal RTA, yeah, if there's any what genetic association is there. Once you do a genetic testing, you actually get a definitive cause for it and you can treat accordingly. So CRISPR and other gene editing technologies, although still in early stages, may offer curative treatment for certain inherited forms of CKD in the future. So when I talk about AI based risk models, there is artificial intelligence tools also can help us in a way. In fact, I Googled it and found that even they can help in patients' health data, lifestyle, and lab results also to predict the risk of CKD and kidney failure. These models can actually identify individuals who are at more risk for developing CKD before they show any symptoms. So there are a lot of things that we have already studied, like EGFR equations that calculate depending upon the creatinine, age, sex, race to calculate kidney function. Then standardized creatinine SS we can use. Plus research are developing the methods for CKD progression based on time dependent covarieties. So modern imaging, like these days, even so kidney biopsy has actually come down, and we are using a lot of other imaging techniques to know the cause and the progression of CKD in these children. So when I talk about the mechanisms of CKD progression in children, so the cause of like various problems like AKI, Charcot, all these may be related to the exposure of the genetic cause may be there, or they may be exposed to some drugs like NSAIDs can be there, there can be chemotherapeutic drugs, then there can be some kind of infections or glomerulonephritis in these children. So all these can progress to CKD, and the mechanism is mainly tubuloendothelial damage plus polyploidy. So polyploidy and nephritis. Finally, so glomerular is basically the center of damage, but secondary to glomerular damage, there is also tubuloendothelial cell damage that we see, which actually results in progression of CKD. So if we can stop it at that point of time, like if we can stop the drugs that we are causing nephrotoxicity, or we can stop the environmental or problem that is there, we can actually decrease the amount of toxicity and decrease their progression to CKD. Like in preterm children, there is already a low nephron mass. So if we can actually follow these children in future, or with AKI we can follow and keep like that. That is the reason why we need to monitor them. We need to measure their blood pressure, monitor for proteinuria. We can actually of CKD progression. So CKD is basically the result of imbalance between the functional capacity of the kidney and metabolic needs of the body. So like hyperfiltration is one of the key that causes that hyperfiltration of the remaining nephrons is one of the key adaptive mechanism that support the residual function and to some extent growth, like poor growth. So if the growth factors, so these two things are very much related with each other. Like if the growth factors are poor, like if the nutrition is not good, CKD may progress. Because the CKD is progressing, so the nutrition is not good. Because these children are having a very restrictive diet, like there are a lot of restrictions on the food of these children, so that is why the growth is not there. And they are supposed to take a lot of drugs. Because of all these drugs, and in a progressive CKD they have loss of appetite, so they are not growing well. Now the other causes, like there is decreased absorption due to uremia as well as bowel inflammation. So all these are the multiple factors because of which there is progression to CKD. So if we can halt these factors, we can actually stop CKD progression or maybe delay the progression of CKD. So these nutrition guidelines, they are from 2009 KDOKI practice guidelines for nutrition of children with CKD. So we really need to improve nutrition in these children, which needs to be tailored as per the age, gender, race, nutritional and growth parameters of these children. And we need to do it according to the cause of CKD as well as the degree of physical activity that the child is having. So most of the time restricting the protein early in the CKD is not needed. Most of the studies have shown that protein should be at the upper end to support the growth. The clinical practice recommendations from Pediatric Nutrition Task Force published in 2000 also suggested the same thing. Even some studies have been on plant-based diet, but not much studies have supported it, though it is still there. Then pleiotropic benefits on blood pressure, intestinal permeability and gut diabasis has been also studied. So the next point is that if nutrition is so important, why we are still not taking care of the nutrition in these children, especially in the first year of life. If we miss that point of time, then probably the growth is always going to be very less, and these children will be always not socially acceptable in their environment because of their poor growth. They are very stunted. So we really need to focus in future the growth of these children. Then we talk about, once we have spoken about the progression of the disease, the nutrition part we have spoken. Now the next is, what are the clinical trials that are ongoing for these pediatric CKD patients? So there are couple of medicines, especially when we talk about medicines like calcimimetics. So these these medicines, these are the calcium sensing receptor agonist. So it is essentially affects the growth of the children. And so if we there are these senile calcite have already been studied in adults, and they have been found to be useful. They cause the activation of parathyroid. So most of these children who are CKD will have already have increased hyperparathyroidism, especially in the middle stages of CKD. So these calcium mimetics, they lower the threshold for calcium sensing receptors activation by extracellular calcium ions, thus PTH from parathyroid cells. So we can really help in extra preventing hyperparathyroidism in children by using these calcimimetic drugs. So lot of studies are still ongoing, lot of clinical trials are going in children also. Then there is another part, if we can actually enroll use these drugs, we can reduce up to 57% of PTH level. Ethyl calcitide is under study in a phase 3 trial in for pediatric CKD. Additional drugs acting on calcium metabolism have been proposed to enter into use for pediatric population in the next few years. Now, when we talk about mineralocorticoid receptor agonist, they are also used to treat low renin or refractory hypertension. Earlier, mineralocorticoid receptor antagonists like spironolactone and eplerenone were not used because of side effects of hyperkalemia and also sex hormone analog analog that they cause. So now studying of this MRA antagonist they are being used for treating hypertension, and a newly highly selective and non-steroidal MRA, Finrenone, has been shown to be effective in improving renal outcome in patients with diabetic CKD. Finrenone is currently being tested in 2 phase 3 open label trials for pediatric CKD patients, Figaro DKD and Figaro DKD. So next drug which I want to talk about is sodium glucose co-transporter 2 inhibitors. So SGLT2 inhibitors, they mainly act through inhibition of tubuloglomerular feedback, which is dysfunctional in CKD. So it reduces hyperfiltration. If hyperfiltration is reduced, then it definitely reduces further CKD progression. So if there is systemic metabolic insult, there is nutrient deprivation, which causes further cytoprotective effects and reduction in metabolic stress, and especially in proximal tubular cells. So this reduces the risk of kidney disease progression. It has already been used in adult CKD. So now there is studies going on in pediatric CKDs. So it also improves kidney and cardiovascular outcomes, but mainly studies have been done in patients with albuminuria, but now it has its role in patients who are non-albuminuric, and also in diabetic and non-diabetic patients it needs to be studied. So then there is one important important drug which I want to talk about, and that drug is for anemia, which is Redoxatat with Vidoxatat and Debistractat. So these are hypoxia. They are hypoxic inducing factors. So they are mainly used. Their studies are being done in adults. They are being used, but I think it is one of the very promising drug to be used in future. Especially there's studies which are going on Roxa Dustat. So the next drug which I want to talk about, I think most of the drugs I've already talked about. So now it's about public awareness and education. So we really need to influence people by asking them to have a healthy lifestyle, prevent obesity, have a more active lifestyle, prevent diabetes and hypertension. Most of the drugs which are antihypertensive drugs or ACE inhibitors, statins, the cost have been reduced because of the generic use of these drugs, so they are freely available for most of the people. Then we talk about the regenerative medicine and stem cell therapy. Research is going into kidneys and bioengineered tissues offer hope for regenerating damaged nephrons. Stem cell therapies are being invested for their role in reducing inflammation and fibrosis in kidney tissue. Though not yet standard clinical practice, but these strategies could eventually replace or delay the need for dialysis or transplant in children. Then there is lot of role for AI and machine learning, which is increasingly being used to improve CKD management. So predictive algorithm can analyze vast amount of clinical data to forecast disease progression, optimize treatment plans. Telemedicine platforms are enhancing access to pediatric nephrologists, particularly in undeserved areas, and improving adherence through remote monitoring tools. So we have been able to talk to patients who are far away through telemedicines and have been able to provide them quality care. So improve dialysis and transplant outcomes. Future developments aim to make dialysis more tolerable and effective, including wearable dialysis devices and improved home-based systems. In transplantation, advancements in immunosuppressive therapy, organ preservation techniques, and tolerance-inducing protocols are expected to improve graft survival and quality of life. There is ongoing research into xenotransplantation and 3D printed organs. Psychosocial and developmental support. Thus, there is a growing recognition of the need for comprehensive care models that integrate psychosocial support, education, and transitional planning to adult nephrology services. Holistic care will be crucial in managing long-term effects of CKD on mental health, schooling, and social development. Talking about a couple of pediatric registries that are already trying to find out the impact of CKD. So Indian Chronic Disease ICKD study. This is a large cohort of Indian patients with moderate kidney failure, 40 to 60% reduction in kidney function, to be followed for a minimum of 5 years. So almost 5,000 patients have to be enrolled. As per September 2017, 2,275 subjects have been recruited and are being followed up. So they develop prediction algorithm using biomarker and study the natural course of CKD in India. Then we have pediatric chronic kidney disease registry at CMC Vellore. So it maintains a biorepository and registry of children with nephrotic syndrome and chronic kidney disease. So this is ongoing data research initiative which is being maintained at CMC Vellore. Then global pediatric CKD registry, which is being maintained by IPNA, and it has global renal replacement registry. So this collect population based information on children receiving kidney replacement therapy worldwide, and data on pediatric end stage kidney disease including dialysis and transplantation. The current status is annual reports are produced and registries collaborates with regional, national and international dialysis and transplant registries. Then Italkit project Italy. So similarly, it is registry that is for children who have CRF under 20 years of age. So it is initiated in 1919, providing comprehensive data on epidemiology of CKD in children. And then the next is the European Dialysis and Transplant Association. So this is data from 12 registries located in Europe covering pediatric patients. It was established in 1964. The EDTA registry has been instrumental in improving ECMO care, post-cardiac arrest management patient, and organ transplant and ventricular assist devices. So the last part of it, conclusion, it is very important to promote disease awareness, ensuring a correct and timely identification of pediatric patients with chronic kidney disease. It is important to incorporate cutting edge technologies in diagnosis, that is the biomarkers that we are using for diagnosing, to understand the disease progression so that we can halt the disease progression, balancing out the need to promote growth and keep CKD under control. Incorporating newly available treatments for CKD resulting from either translation of results from clinical trials in adults or as directly designed for the pediatric CKD population. Thank you.
For that insightful presentation and highlighting all the drugs which are in trial right now and all the CKD registries. So, and I would like to congratulate both the speakers to maintain the time frame. So kudos to both of you. So we have finished in time. And now we can take few questions. So Sudarshan, Dr. Sudarshan, I would like to ask you, you have told about all the biomarkers. So are you planning to do anything on anti-nephrin antibodies? Like furosemide test you told you have already done. So what is the current?
Yeah. So we have just applied and starting the study, we have put up a project on anti-nephrin antibodies. It is just in the ethical board. So a long way, probably in 2 years from now, we'll have some data from Indian study. There is also an ICMR approved study at All India Institute, where just recently it got approved from ICMR. So they've also initiated their study. Probably in the next 2 to 3 years, we'll have some Indian data on how about this anti-nephrin antibodies, how frequently this is when compared to what is available so far. So the data so far is from the US and Italian centers. So we definitely need much more. There's not much from Asian as of now. Probably in some time we'll get to know these things.
Thank you. I would request the participants to please drop your questions. Thank you.
I think there
Yes,
was
sir.
one question for Sudarshan. I think he has answered it. He has typed out the answer. I think you have to read out because usually we take out the questions verbally. Not
Sure.
everyone
So I'll
needs to
just,
see the answers.
yeah. So the question was on, can we use CKD-EP equation for adolescents in the post-pubertal age group? So if you carefully look at the CKD-EP formula and the, the population from which this equation has been applied, it is really from 18 years upwards. Okay, so they have looked at the adult data. Basically, there are some few population which is below this cutoff, but not really robust data to say that the CKD-EP formula works so well in this age group. I do understand that the modified Schwartz, if you look at the bedside Schwartz, which we all have been using, even in that study, the upper cutoff was only 16 years. So if you look at data-wise, Probably till 16, the bedside Schwartz is good. CKDP, not recommended less than 18 years, probably 18 years and above. So that's why the secret 25 has come up, where they say up to 25 years, you just use one formula. The only difference is change the constant based on the age and gender of that patient. But as I said, we need more data on this also.
Dr. Neha, I would also like to ask you, what is your experience with silacalcet or etacalcitate? Have you tried working with those drugs yet?
We have tried cinalcalcet for two of our patients, but I think when like this, since the data is very limited, so we have tried for children who had hypercalcemia, which was not being controlled with any of the drugs, like on dialysis also, but they were still having hypercalcemia. But then it worked really well for these patients. We were able to control it within a period of like 2 months, and then we could stop it, and the calcium is still okay. So sometimes these CKD children who are on dialysis, you would really find them very hypercalcemic, and even after dialysis, it will not be well controlled. So I think it worked in these children.
Right.
And plus,
Thank you.
I would like to state about these drugs also. I think we should also try to use the once we have data on these HIF2 inhibitors, because I think they seem also very promising and interesting to me.
Thank you once again, Dr. Sudarshan and Dr. Neha. Ma'am, I cannot see any more questions in the Dropbox. So over to you, Dr. Kalevan.
It was a great talk, Sudarshan and Neha. Like, thanks, Mansi, for moderating the session. Amrish, do you have any questions for the speakers?
Yeah, no, these are excellent talks, and I just have a few comments. And again, Dr. Sudarshan covered so nicely all the biomarkers, and one of the last biomarker that he covered was the cell-free DNA testing. And personally, I do have some experience here doing cell-free DNA testing, and it is becoming more and more in use for clinical purposes. I think the data, as Dr. Sudarshan had nicely shown, is there now, and it's slowly, being used more and more. One of the advantages that we have seen with cell-free DNA is that it can detect rejection even before the creatinine has started to go up. So I think it gives us a good lead time. I totally agree that it has not replaced the biopsy yet. And, I'm not 100% sure if it's going to replace the biopsy because it does not tell you what kind of rejection it is. It tells you that yes, there could be rejection going on when the cell-free DNA is high, but you don't know whether it's AMR or whether it's cellular rejection. And that's how you don't know what therapy to target. But at least for detection purposes, I think it's a great tool. I recently detected, 3 AMR just because there was some suspicion of non-compliance in the patient. There was either like they were on dual immunosuppression or, the new DSAs were there. So those were the indications that we did the cell-free DNA with a normal creatinine. In all these three circumstances, a normal creatinine, but there was some suspicion, and then we found AMR on the biopsy and then treated them, and definitely the response was very good. So I think it's coming for sure, but is it going to replace the biopsy? Time will tell us. But there was again a very good compilation of what cell-free DNA is, what are the advantages. I think that was wonderful. So thank you for sharing that. And then for Dr. Neha also, again, excellent talk. And she showed us what the future is going to be like. And she showed us that, how AI can be integrated. We know we are trying to integrate AI in everything here and how AI can help us in managing of chronic kidney disease patients as well. And again, what we are studying here is how AI can be integrated into the electronic medical records. Again, the hospitals that have electronic medical records, it gives you a lot of data. Once you have a lot of data that can be put into the machine learning tool, once that is there in the machine learning tool and somebody is ordering a medication, then the creatinine pops up, the GFR pops up. It's more like an automatic alert for the prescriber that you need to change the dose of the medication that you're giving, that you need to be careful what medications you're using. I think it just helps you in better management. But definitely that's when you have electronic medical records, and that's how AI has been helpful as well. So again, those things will come up, and using AI in CKD, again, that was a very well covered, topic. So thank you, Dr. Neha, for doing that. So yeah, it's a more of comments than anything else for me. So thank you both speakers. This was a wonderful talk and a wonderful last session. Dr. Kalavani, I'm gonna share
Yeah.
the slide. I think
Yeah,
everybody has been
please.
waiting for. So it's all you now.
So the last few webinars, we had been having the polling sessions for the pediatric trainees and fellows. And so today will be the announcement of the polling sessions. We have three winners, and we are very much aware all three winners haven't participated in all the webinars, but still they have made for 4 or 5 webinars, but still they were able to manage to get the first, second, and third place. Can we move on to the next slide? So the first winner is Dr. Supraj Shivaramakrishnan. He's a pediatric trainee from JIPMO Pondicherry. I think he's from the same institute where Sudarshan is right now. And the second winner is Dr. Sangeeta. She is from KEM Pune. And she is also doing her DRNB pediatric nephrology. And the next winner is Dr. Preeti. She is DM nephrology, adult nephrology, who's from Stanley Medical College, Chennai. So all three have done their best, and they'll be offered cash rewards. More than cash rewards, it is their enthusiasm which had voted in the success of this program as well. Congratulations to all the three winners. Namalva sir, do you have anything to say for the winners? Namalva sir is there around. Dr. Amrish, Namalva sir is there around.
Yeah, I see his name and he's muted.
Okay, fine. This being the last session, I really want to thank one and everyone. And I extend my deepest gratitude to all the faculties who had been part and parcel of our program for sharing their insightful and engaging presentation. Their presence and expertise have truly enriched our understanding of pediatric CKD. I think all participants would agree to it. And a special thanks to our pediatric team, Dr. Namalwar sir, and our fellow Dr. Charan, Dr. Keetana, Mr. Kabil, our medical social worker, who had been always there in hospital working on it like a mission. Thank you so much. Of course, I should be thanking Dr. Amrish. Many times I'm not there in the picture, and Amrish is the part and parcel of this program, and he's a course director, and he had been taking care of the webinar series for the last 2 to 3 years. Thank you so much, Dr. Amrish, for your tireless effort in making this event a resounding success. And I should really appreciate the dedication and the enthusiasm of all the participants. And big thanks to the International Pediatric Nephrology Association, Indian Society of Pediatric Nephrology, and Tanker Foundation for their generous support, which made this event possible. Finally, I want to express my sincere thanks to each and every attendee, because without attendees, I think this program wouldn't have been possible. Thank you so very much. I think next year we might go on with a more interesting topic on pediatric renal transplantation with the support of IPNA. Can we request the winners to say a few words and comment on how the questions were, like how do we have their feedback on the polling session as well? I think winners are there in the panel. They can unmute themselves and speak. The first winner, Subaraj Shivaramakrishnan, he's there around?
Supraja. I think Supraja is there. Is she here?
Supraja, because in my mobile I'm not able to actually view the names.
Yeah, Supraja is there. Supraja, you want to say a few words?
She is unable to mute. I think
Unmute.
can the IT team help in unmuting her? Supraja, are you able to unmute yourself now? IT team is there around?
Yes, ma'am.
Okay, can you please unmute Supraja, Sangeeta, and Preeti? Because they are not able to unmute themselves.
Hello, ma'am. I'm Dr. Preeti.
Hi, Preeti. You're from doing your
I'm
DM
from
F
Stanley,
from
ma'am,
Stanley.
adult nephrology. For me, it was very nice to know about the nutrition part of pediatric vaccinations. A completely different world, though similar. I had an exposure to how it is in different stages of this webinar, ma'am. So I found it interesting. And the questions also followed up, enlightened me to know better in this field. It is similar, but there are its differences, and it was good to know all of this.
Okay. Congratulations, Dr. Preeti.
Thank you, ma'am.
Is there anyone else who wants to speak? Otherwise, we can go ahead closing the session.
Hello, ma'am.
Yeah. Hi, Supraja.
Yes, ma'am. Yes, ma'am. This is Supraja, ma'am. Second year pediatrics resident in JIPMER, ma'am.
Okay.
Actually, I didn't expect this. I just attended few sessions and I thought maybe like I wanted to attend all the sessions, but I had duties in between. So I thought, but I listened whatever sessions I attended, I listened to the classes properly, and the questions were mainly based on whatever was taught. So I think that was very helpful, ma'am. Yeah.
Okay, true. But we noticed that all three winners have not attended all the 7 webinars.
Yes, ma'am. Yes, ma'am. Yeah. It was
Congratulations,
very,
Supraja.
yeah. These sessions are also on YouTube for future reference. So that is very helpful, ma'am. Yeah.
Yeah, you were able to compete with the DM nephrology trainees as well. Congratulations.
Hello,
Thank you so much, ma'am.
hello, ma'am. I'm Dr. Sangeeta. Actually, I'm doing adult nephrology.
Okay.
So I also attended few sessions, and that was very helpful for us, especially the vaccination session. So uh, it is very good. I am looking forward to attend more sessions for the year. Thank you so much for this opportunity.
Thank you. Thank you so much, Sangeeta. Congratulations once again to all the winners. Dr. Amrish, you have anything to say?
No, congratulations to all the winners, and it's very good to see that even adult nephrology trainees are interested in the program. And definitely, we want more trainees to participate in this. Do please let everybody know, your colleagues know, that this is open to both pediatric and adult nephrology colleagues. And I know Dr. Kalavani also sends it to pediatricians because we do try to focus some of the topics for pediatricians as well, because that is also important. And again, this was excellent session. I think excellent total webinar series. And I would like to thank IPNA. I would like to thank Mehta Children's Hospital's entire team who has worked tirelessly, and of all, Kalavani, who's the brain. It's her brainchild, and she has tirelessly worked for the last 5 years on this. So thank you, Dr. Kalavani.
Thank you, Dr. Amrish. Thank you, Neha. Thank you, Sudarshan. Thank you, Namalva sir. I think we can close the session.
Thank you, Kalaivani. It was wonderful being here.
Thank you, Neha. It was a wonderful talk to
And
let
thank
us
you,
know
Dr.
what is the
Mansi, for
future of
conducting
pediatric
the
nephrology.
session.
Okay.
Thank you, Dr. Amrish. Thank you, Dr. Sudarshan.
Thank you. Thank you.
Bye bye. Yeah.
Thank you, Dr.
you.
Mansi. Thank you, Dr. Sudarshan. Thank you, Dr. Neha.
Thank you, sir.
Thank you, Dr.
Thank you.
Amalwar.
Thank you, Mansi, for the wonderful moderation.
Thank
Bye-bye.
you.
Thank you. Yeah.
Bye.